Welcome to Trauma Life Support Malaysia. This is the Airway Skill Station. In this station, we will demonstrate on techniques of managing the airway and introducing airway devices that are commonly used in trauma patients. Students are expected to be able to perform all the techniques in this skill station. Let's learn.
This is nasal prong, or known as nasal cannula. Connect the nasal prong to the humidified oxygen supply and set the flow of the oxygen not more than 5 liters per minute, which delivers oxygen concentration of 28 to 44%. Anything higher than 5 liters per minute can result to discomfort, drying of nasal passage, and epistaxis. Also, with flow rates of more than 5 liters per minute would cause laminar flow to become turbulent, which is less effective. This is rebreather face mask. It is used to deliver higher concentration of oxygen at the higher flow. After connecting the tube to humidified wall oxygen supply, set the flow 5 to 10 liters per minute, which delivers oxygen concentration from 40% to 60%. This is a non-rebreather mask, or known as high flow mask, which can deliver high fraction of oxygen in the spontaneously breathing patients. There is a reservoir bag attached to the fresh gas flow with one-way valve between the reservoir bag and the patients. This is to prevent expired gas entering the reservoir bag. It delivers FiO2 between 0.6 to 0.9 or 60% to 90%. Assemble the equipment and attach it to the oxygen supply. Ensure that the reservoir expanded with flow preferably 10 to 15 liters per minute. This is a Venturi face mask. It gives us the flexibility to adjust oxygen concentration to be given to the patient. Choose the correct Venturi valve that is prescribed to the patient according to the color and FiO2 printed on it. It comes with the intended flow rate to achieve FiO2. Now, assemble the equipment. And attach it to the oxygen supply. This is Oropharyngeal Airway. It is an adjunct to obtain and maintain airway opening in unconscious patients with no gag reflex. It helps to relieve airway obstruction by move the collapsed tongue and hypopharyngeal structures forward. It comes in various sizes. This OPA, or Oropharyngeal Airway, needs to be properly measured before inserting into patient's airway. It can worsen airway obstruction if the size is too small because the distal end of this OPA will be blocked by the tongue. If it is too big, it can cause traumatic injury to the surrounding area and laryngeal spasm too. This is Nasopharyngeal Airway, known as NPA. It is an airway adjunct to help to obtain and maintain open airways. Can be used on semi-conscious patient or unconscious patient with gag reflex. It can also help in patients who need frequent nasal tracheal suctioning. NPA comes in various sizes. This NPA needs to be properly measured as the tip of NPA may enter the larynx or into the valvulae, causing coughing, gag reflex, and eventually airway obstruction. If it is too short, it may not be able to separate the base of tongue, soft palate from pharynx. This is a laryngoscope. It has two parts, the handle and the blade. There is normal handle and there is short handle. This is important as you might need the short handle laryngoscope on patients with short neck, big chested or barrel chest. The blade came in few types and sizes. Commonly used curved blade or known as Macintosh. The common size for adult, for female, size 3, and for male, size 4. This is a McCoy blades. It has a movable distal tip to lift the larynx forward. This is straight blade for children. It has size from size 00 until size 4. Ensure that the bulb is functioning. By holding the handle, connect the blade and the handle via its hook of the blade. Open it up and check the bulb like this. This is a Magill Forceps, an additional instrument that you need to prepare if you are going to intubate a patient. It is a twin-bladed, tongue-like forceps. It has a rounded end for grasping and an oblique angle between the head and the body so that the view would not be obscured. Among the usage are, it can remove foreign body, it can be used to manipulate soft tissue to facilitate intubation. It can also be used as an aid in pharyngeal, laryngeal packing in case of bleeding. And it also helps ETT, nasal ETT, or orogastric tube insertion. This is a back valve mask device. It is used to provide oxygenation and ventilation prior to intubation. It consists of 3 major segments: mask, bag, and reservoir. This is the mask. It has to be fitted to the patient's face, covering nasal bridge, cheek eminence, and above the chin border. Please choose the appropriate size. This is the bag. It has few important valves to ensure one-way flow of oxygen supply to the patient. It is called as membranes. The bag has 3 sizes. For adult, 1.6 liters. For infants and children, we use 0.5 liters. And for neonates, we use 240 mils. This is the reservoir. It comes in 2 sizes, 600 mils and 2600 mils. Now, let's assemble the device. First, make sure all the membranes are there. Then, connect the back valve mask to the oxygen supply and ensure that the reservoir bag is expanded well before applying it to the patient. This is an endotracheal tube. As you can see, this transparent PVC tubing comes in anatomical curvature that conforms to the shape of the neutral airway position with a standard 15 mm universal connector at the tip. This is the cuff and uncuffed ETT. The usage depends on the clinician's intention of treatment. There are two reasons for air-filled cuff, which are to seal the trachea from positive pressure seal and from secretion leaking into the pulmonary area. It has to be filled with air with pressure at the about of 10 to 40 centimeter water. It can be measured with manual manometer. Or you can roughly measure the cuff pressure by pressing the pilot balloon. There is vocal cord marker where the vocal cord should be under direct supervision. Depth marker to mark your depth of ETT. Murphy's ice acts as additional event should the main lumen is blocked with phlegm and preventing right upper lobe collapse. The blue line here is the radio-opaque line to indicate the position of the tube on X-rays. This is a gum elastic bougie, or commonly known as bougie. It is 60 cm long with a diameter of 10 to 50 French marked at every cm and has a form of hockey stick shape at its distal end. During intubation, the bougie is inserted at the side of the mouth because it is easier to be rotated for a better control. The bougie should be rotated 90 degrees anti-clockwise, avoid the bevel end hitting the arytenoids. The user should feel clip as it passes along the tracheal ring. Using the surgical technique, slide the ETT on top of the bougie while maintaining the depth of the bougie. This bougie can also assist in surgical airway procedure and supraglottic airway tracheal intubation.
How to open airway? In opening airway in a trauma patient, one has always have to assume the possibility of a cervical injury. So there is no head tilt chin lift in opening airway for a trauma patient. First, we have to do an inline immobilization to secure your cervical. Right. Then we will release the cervical collar. Two methods in opening an airway. One is by doing jaw thrust. With two thumbs at your malar eminence, two fingers at the angle of the mandible, and do a jaw thrust. You can either do it this way, or you can place the palms at your malar eminence, again two fingers at the angle of mandible, and jaw thrust. The other method that we can do is chin lift. Two fingers at the chin and pull up, chin lift. No head tilt chin lift is required for a trauma patient. Removing foreign body with a Magill Forceps. First, we need to open the mouth. Visualize and see whether if there's any foreign body seen. Oh yes, there's a foreign body, Magill Forceps. Remove your foreign body. Once the airway is open, look for any foreign bodies. If it is a hard object, remove it with a Magill Forceps. If it's secretion, we will do suction. Suction is functioning in your airway. Suction. For pediatric patients, we will be using a soft suction. So insert this, then suction. Insert it again until the maximum that you can go. Suction. Next, we will need to insert an oropharyngeal airway. First, we need to measure. There are two ways of measuring. One is from the corner of the mouth to the tragus. This is not the correct size. So again, get the appropriate size from the angle of the mouth to the tragus, or from your incisor until the angle of the mandible. So once you get the correct size, place it this way into your oropharyngeal until you hit the hard palate. Turn it around 180 degrees and push it in. Another method that you can use is to use a tongue depressor. Gently insert your tongue depressor, gently depress your tongue caudally, and place the oropharyngeal airway directly. If your patient has got a gag reflex, we cannot insert an oropharyngeal airway, therefore we will insert a nasopharyngeal airway. First, we need to measure is from the tip of the nose until your earlobe. Or your other method of measurement is with the patient's little finger. Insert it gently, apply gel. Okay. Insert it gently through your nostrils and with gentle twisting movements, slowly insert it until its maximum. This is your supraglottic device. Choose the appropriate size according to your patient. First, we need to partially inflate your LMA. Once it has gained its shape, apply gel to the anterior segment of your LMA. We need to hold it like a pen. Open your airway, gently insert your LMA. Push it in until the maximum that it can go. Further inflate your cuff. Proceed with your bag. This is inline immobilization. We would fix the patient's head and neck by gripping the forearms, your fingers at the back of the shoulder and your thumbs at the clavicle. You will require assistance from your second colleague to remove the cervical collar. I would change to here. Okay, remove the cervical collar. Okay. Mr. Nazri, kindly take over. I would proceed with preparing for intubation. Back valve mask. Ensure the mask is of a correct fit, whereby it's covering your nasal bridge, your prominence, and also at your chin. Once you have selected the correct mask, fix your mask to the back valve mask. Apply the mask, CE clamp, and ventilate and oxygenate the patient. Intubation. First, pre-oxygenate the patient. Ensure there's adequate chest rise. There's poor chest rise seen, I would need an oropharyngeal airway. Back valve mask. Ensure there's good chest rise and there's a good CE clamp. Once patient is pre-oxygenated, we will proceed with intubation. ETT. Remove your stylet. Auscultate for air entry. In situations when there is difficulty in intubating, we would require a bougie. insert your bougie from the angle of your mouth, slowly guide in, rotate anti-clockwise, insert until you feel the grittiness of your hand. Alright, I'm in, can you insert? Okay, hold the top. Okay, inflate. Remove. Once the patient is intubated, reapply back the cervical collar. Ensure inline immobilization is always done. Then secure your ETT tube. Double knot is required. Okay. Connect to ventilator and proceed with post-intubation care.